Welcome back once again. This is the cerebellum, and this is going to be the first part of a two-part series as it relates to the cerebellum. The cerebellum is so complex that we really have to break it up into two sections. This first section, I have to tell you, is going to be a lot of didactic. It's going to be, this is going to be one of the tougher ones from an academic standpoint. I'm going to do my absolute best to simplify it where we can and walk through this in this way. Now, in the second part, what I'm going to do is we're going to put everything into the practical. I'm going to show you a whole lot of examples of different examinations that you're going to do for the cerebellum, and you'll have all your examples in the next video. But for this section, we're going to talk about more of the academics. So let's get into it here. First off, let's look at the brain right here, and we talked a little bit about this in our previous modules. Here's our brain stem. Here's the cerebellum. If you remember, the cerebellum gets information from the eyes, what's coming in the vestibular system, what's coming from the brain, and what's coming from the body. Okay? So when we look at cerebellum, I'm going to break it down into three functional categories. We're going to talk about things in relationship to three functional categories. We're going to talk about what's called the cerebellum, excuse me. We're going to talk about what's called the spinocerebellum, and we're going to talk what's called the cerebrocerebellum. We're going to break it down into these three categories because I believe that will help simplify and get us to where we need to go as upper cervical doctors in performing this examination. Okay, so first off, just a little bit of a look at what it looks like right here. Here's the midline cerebellum right here. Here's the intermediate we talked about the other day, and here is the lateral cerebellum. Now, keep in mind, the midline cerebellum, this is what we find in the lowest forms of animals. This is hooked up basically to the eyes and to the vestibular system. That's where it gets that's the most important inputs to the midline cerebellum. And as I say, the lowest animals, and I don't, you understand what I'm saying, the lower animals have a need for protection. They have to be able to see, and they have to be able to know where they're at in space and time for the vestibular system to stay as a survival mechanism. Now, as you get higher developed animals will actually have an intermittent or intermediate cerebellum, and we would call that the spinocerebellum. And this has to do with getting proprioception from the body and making appropriate adjustments. And then, as we talked about in the previous module, this is the lateral cerebellum. This is what's hooked up to the cerebro, or the cerebral cortex. And so this is the connection between the cerebellum, cerebral cortex is the cerebellum. So only the most highly developed in humans are going to have the most highly developed lateral cerebellum, because, as I said before in the previous module, that cerebellum development has everything to do with brain development. And one of the things I would add to that is one of the things that they talk about as human beings, us being bipedal, us walking, with 2 feet. We're not walking on all fours, we're walking on 2 feet. Because we walk on 2 feet, we have to have a different level of balance, a different level of equilibrium. We have to have a much more intricate, much more involved balance mechanism, and that's one of the things that contributes, actually, they say, to the lateralization of the brain. It's quite interesting. Okay, so let's talk about the cerebellar anatomy. Here we go. Right here, the blue right here would be considered functionally. It's going to be functionally can be considered the vestibular cerebellar. This up here is the anterior cerebellar, and this is the posterior back here. And if you look here, let me get my white out because I do want to highlight this right here. This right here is the cerebellar tonsils. So those are the guys that can be low-lying in those issues we talked about in the CTE. Okay, so functionally, what do we look at? What are we looking at? Here we have the spinal cerebellum here. We have the cerebral cerebellum here. And right here we have our vestibulocerebellum. Okay? So just like I said, let's don't get too hung up on the anatomy. Let's think about this from a functional standpoint, because when it comes down to it, that's really where we're going to live with this thing. Okay, so there are 3 functional divisions of the cerebellum. Now, there's the vestibular cerebellum, as we talked about. This is the flocculonodular lobe and its connection with the vestibular and vestigial nuclei. I'm going to explain that in just a little bit. The spinal cerebellum, this is the vermal or paravermal. Another way to say that would be the intermediate zone, and their relationship with the interpost and vestigial nuclei. It receives all of its input from the body. And as we said before, the vestibulocerebellum is receiving most of its input from the eyes and from the vestibular nucleus and the vestibular, I should say, system. And the cerebro is getting its information from the brain. Okay? So the lateral hemispheres receiving information exclusively from the cerebral cortex. All right, so here's another picture. We're talking about this being the, let me get my black back out. This right here being the center and having to do with the vestibulo. This has to do with the vestibulo. This having to do with the spinal cerebellum, and this has to do with the lateral. Okay, very good. I think that's we're good, going good on that. All right, so now just to go ahead and summarize just some things we talked about. We're talking about 3 functional divisions, and let's don't get too hung up in the intricacies of it, but let's look at it from just a broad category, because for our upper cervical work and doing our examinations, that's really what we need to know. Those are the need to know things. Okay, so now the next thing is there are things in the cerebellum, how they communicate to and from the brain and from the body and so on and so forth, is through the peduncle system, the peduncles. We have a superior, inferior, and a medial peduncle. Now let's talk a little bit about this. Right here is the superior peduncle, and right here is the middle peduncle, and right down here is the inferior peduncle. That's how information goes into and goes out of that cerebellum. And so let's put some words around this. Okay, the superior cerebellar peduncle. Its majority is the interpost and dentate nucleus outputs that go up to the cerebrum. And you know, before I go any further, let me just back up, because I think that it would be helpful for us to describe something here. Let's see here. I apologize. I have a slide here that I want to show. Okay, let's start right here, and let me show you here. Okay, inside, in the deep, so we have a cerebellum. You know, we have our cerebellum that hangs out like this. Okay, so here's my brain stem, and here's my cerebellum hanging out in the back. Okay, better yet, let's do it this way. I apologize for the mess up here. Okay, so let's take the brain. Okay, we want to make this real. Okay, so here's the brain stem, spinal cord. Here's the cerebellum. Deep inside the cerebellum, you have what are called deep cerebellar nuclei. Okay? There's deep cerebellar nuclei. Okay? Now, let's look and see which ones we're talking about here. In the middle cerebellum, you're going to have a pair of what's called vestigial nuclei. Vestigial nuclei, meaning more than one. Vestigial nuclei. This guy is majorly hooked up with the vestibular system. This guy communicates with the vestibular system, and also communicates with the eye movements, and has a few other communication points. Then inside here in the intermittent zone and the paravermal zone in the spinal cerebellum, we have what's called the interposed nucleus. These are interposed nuclei, okay? There's two of them. One is called the globus, and one is called emboliform. So you have an emboliform nuclei, you have a globus nuclei, and when you put them both together, they call them the interposed nucleus. That's another part of the deep cerebellar nuclei system. Okay? Now the next thing is we have out here, and you see how big this is, you have what's called the dentate, not to be confused with the dentate ligament, but you have the dentate deep cerebellar nuclei. It's a dentate, and it's the one that's hooked up directly to the cerebral cortex. So the dentate ligament has outputs to and from the cerebral cortex. The interposed nucleus has inputs and outputs from the body. The vestigial nucleus largely has inputs and outputs that go from and to the eyes and to the vestibular system and from the vestibular system. So in summary, we've talked about three functional divisions. We've talked about the vestibular, we talked about the spinal, we talked about the cerebro. Now we've talked about deep cerebellar nuclei that's within the cerebellum, okay? All right, so let's move forward. All right, so this slide will make a little more sense now that we've discussed that, I think. The majority of interposed and dentate nuclei outputs go up to the cerebrum through that superior cerebellar peduncle, okay? And this is hitting in the midbrain, all right? So we're going to have ventral spinal cerebellar tract comes in here, and locus coeruleus noradrenergic fibers. Do you remember what comes out of the locus coeruleus? It's norepinephrine. Norepinephrine is one of the things, it's a catecholamine, and it's one of the things that actually activates things like the hypothalamic pituitary adrenal axis. It's one of the things that drives the sympathetic nervous system response. So when you think norepinephrine, think adrenaline, noradrenaline, think sympathetic nervous system, think autonomic nervous system, think these things when we think about the locus coeruleus and the noradrenergic fibers. Now, let's talk about this just a moment. I don't want to get too lost on this, but this is a very, I can't put too much emphasis on this, because when you are walking, when you're walking, and this is going to be a really bad drawing of a person walking. I can't go down to walking. But anyway, okay, so you're standing here. You're moving this way, you're moving that way, you're moving whichever way you're moving. On a continual basis, to keep you upright, blood has to be shunted to muscles and away from muscles all the time. Because when muscles move and muscles activate, they have to have blood supply. In order for them to have blood supply, there has to be an organizational center that actually is shunting blood from one place to the other. And guess what controls the shunting of the blood? That's right, norepinephrine is a major neurotransmitter when it comes to constricting the blood vessels. Okay, so why this is important is because the cerebellar vestibular system is a major player in shunting this blood, and therefore it has a major function in the overall autonomic nervous system response. So when we talk about a cerebellum that's not functioning properly, I'll give you an example. Here's a really good example. From a historical standpoint, if somebody has cerebellar issues that's coming out of the vestibular cerebellar primarily, one of the things that you can see is going to be they will get car sick. Why is that? Because they're driving down the road, or usually when you're driving, you don't have as much trouble. But if you're in the back seat, you're reading or doing something like this, you have things flashing by you in your periphery that you might not be paying attention to, but your brain, your eyes, is bringing that information in. And if you have an issue with that vestibular cerebellar system, it can cause problems in how it's shunting blood, and it can cause that autonomic nervous system to go upside down, and then all of a sudden you can have things like, well, car sickness. You can have you know, a vagal response, and when you have that vagal response, that's when we get the nausea and we get the different things that come with that. The next thing is from a historical standpoint, if somebody says, wow, I just get anxiety. If I'm in a crowd, I always get anxiety. This is another case that's happening. They're in a crowd, there's lots of things happening on, maybe there's lights going on, there's noise, there's people moving around, it's real busy, there's hustle and bustle, all these things are going on, and what it's doing is that vestibular cerebellar system is not keeping up with it, and it's not gating its output, and therefore it's doing way too much, and it's firing off this sympathetic response to such a degree that all of a sudden now they start having anxiety. They start having things like panic attacks. They start having other issues that are actually related because the cerebellum is hooked up with the autonomic nervous system. Now, those are examples that we can point out that happen in an immediate, like right now you get car sick, right now you're in a crowd, you have anxiety. But what happens on a low level when somebody has cerebellar issues and it's tweaking that autonomic nervous system over a long period of time? Do you think that can have anything to do with people growing sickness and disease? It absolutely can. So there's just an important point for you. I didn't want to get too lost in it, but I didn't want to skip that either. Okay, so now we're talking about the peduncles. Remember that the superior is going to the midbrain. The middle cerebellum is the pons. This is almost exclusively pontocerebellar fibers. Now, check this out. Let's talk about our brain again here. And here's my, I'm going to try to be more accurate this time. Okay, here's my cerebellum, and here's my middle peduncle. Now, as we talked about in the cerebellar basal ganglion frontal connection, when the frontal lobe decides to move, then it's going to send down fibers down to the cerebellum, and then oh my goodness, I did that incorrect. Let me back up just a second. I so apologize. Let me take that line off, and let me do that again. So the brain, the frontal lobe, is going to bring information down to the pons. Do you ever wonder why that pons has that little pouch hanging out? The reason why it has that pouch hanging out, because it's full and rich of nuclei. And this is the major input from the brain to get to the cerebellum. It goes to the pons first, and then it goes to that middle cerebellar peduncle, and then the cerebellum does the things that we talked about that it does. Okay, so the inferior peduncle is largely has to do with what's called the olivocerebellar fibers from the contralateral medulla, the opposite side. You also have these things, the spinocerebellar, you have the vestibular, arcuate nucleus, trigeminal raphe nucleus, that's where you get your serotonin, reticular formation, afferents, and vestibular output. Okay, hold on just a second. I got a little issue here. Oh, good, we're all fixed. Good. All right, so now I want to continue on with this thought now. This is another interesting point here again that I need to make that doesn't have to do with the examination, but I think it's good to understand. Right here, this is going to be our inferior olive. Okay, so here's our inferior olive. Our inferior olive, what it does is it gets information from the core muscles, from the core postural muscles. Okay, so we're getting information to the inferior olive from the core muscles. right? Now, the inferior olive is going to have fibers that go into the cerebellum like so. Let me get my white out. That go into the cerebellum like this, and these fibers are called climbing fibers. These fibers right here are called climbing fibers. Climbing fibers. There's going to be a distinction here in a moment, so I'm putting that out there. So you have climbing fibers from the inferior olive to the cerebellum. Okay. Now, what this does is this sets an oscillation rate in the cerebellum. So the cerebellum is actually oscillating, and it's like a pacemaker, if you will. So core muscles feed into the inferior olive. The inferior olive is feeding into, via climbing fibers, into the cerebellum, and that's setting the oscillation speed in hertz of the cerebellum, somewhere around 10 hertz. Now, what's interesting is this, is then the cerebellum in turn is going to do this. Okay, so we get from the inferior olive, we have our core muscles. Inferior olive to the cerebellum, and that sets the oscillation rate. The cerebellum has communication with the thalamus. And the thalamus has a lot of different functions. It's like the quarterback of the brain. It's making all kinds of decisions and making all kinds of plays. But one of the things that it does is through the input from the cerebellum, the thalamus is actually going to set the oscillation rate of the brain. It's going to set the oscillation rate of the brain. So you can imagine where I'm going here, that if you have a slow brain, it's not going to function very well. Or if you have an oscillation rate that is not appropriate for what's going on in your brain, and your brain waves are not where they need to be, you're going to have a problem. I wanted to show you that because of this connection between the inferior olive and the climbing fibers and what's going on with the core muscles. That's one of those lifestyle things you do. I'm going to make sure that my patients have a strong core. It's just a very basic thing. Make sure their core is strong because it's a major feeder into that, major activator into the cerebellum. And cerebellum, we already know how important that is. Okay, so what are the measurable things that we can see that you can see with involvement of cerebellum? Well, basic posture, gait, stability, ocular function, tremors, rapid and coordinating movements, muscle tone, smoothness of muscles. Now we're going to break these down, so let's look at them. So cerebellar dysfunction. Endpoint tremor. We're going to do a whole video just on tremors. We're going to show you the difference between resting tremors, physiological tremors, and endpoint tremors. Endpoint tremors basically is this, and you're going to see demonstrations on the next video when we show you patients. But an endpoint tremor is like the finger to nose. You touch your finger to your nose. Your hand comes up, and when your finger gets really close or gets closer to the nose, it takes more fine motor movement to actually set the tip of your finger on your nose. And as you do that, if your cerebellum is not controlling that fine motor movement, you can get a little shake at the end or a more pronounced shake. That would be called an endpoint tremor. Some people can see this when they're trying to eat and, you know, their fork kind of, vibrates or whatever. Postural sway. Titubation. These are usually seen in what's called an essential tremor, titubation. We're going to show you an example of that as well. And you'll see it with a head shake. Somebody has just this head shake. Sometimes you can't see it very well because people can become very good at hiding titubation. Impaired check. I'll show you an example of that tomorrow. That's basically where you push somebody and do they come right back to where they were, or you move their arm, does it come back to where, you know, where you first started? And I'll show you an example. Dysdiadochokinesia. A lot of people know this one. This is kind of rapid hand movements or rapid foot movements, and you're going to see if things stay in pattern. Dyssynergia, are you able to keep the muscles in coordination? A really good way to check that one out is have somebody do a half sit-up and have them hold it and see how well they do it. And if they start having breakdowns in a little bit, that's a sign of a messed up cerebellum. That's a sign that they have dyssynergia. Dysarthria, this is the famous Katharine Hepburn speech. You know, she talks like this or she talked like that. What that is the Broca's area in the brain, in the frontal lobe, is where you get movement that gives you the ability to articulate speech. Well, it is movement, and if your cerebellum's messed up in a certain way in the lateral cerebellum, what will happen is the Broca's area can be affected, and so the cerebellum is not packaging and making that movement awesome, so you get a disrupted speech that sounds like that. So you can also have cognitive changes. We talked about that one already. Dysmetria, that's movement. That's dysfunction in movement. Dysmetria can also be seen in eye movements. It can be seen in any kind of movement of the body that's not coordinated. Dysphagia, of course, swallowing is just a function of muscles having to coordinate between relaxation and contraction. And when you have problems in the cerebellum, this can be affected. Ataxia. There's a big thing about cerebellar ataxia. Of course, this is gait. This is the one that people see, you know, when they've been imbibing, you know, drinking alcohol. You can have alcohol-induced ataxia, and so on and so forth. But also people can just have cerebellar disease, disorders, different problems. Upper cervical subluxation can cause dysfunction in the cerebellum, can cause you to have ataxia as well. Extraocular changes. Eye movements are completely hooked up with what's going on in the cerebellum because of the vestibular system. Hypotonia, you know, there's something that's really important that we need to mention, and let me mention that here if I've got space. Yes, let's do it here, okay? So here is the brain, here's the nose, here's the mouth, here's the brain stem, spinal cord, and here's the cerebellum, okay? So one of the things that happens is the vestibulospinal tract, one of the things that it does is activates the extensor muscles. So it activates the extensor muscles, okay? So one of the things that cerebellum does when we have movement that's initiated here, then the frontal lobe communicates with the pons. The pons through the middle cerebellar peduncle goes into the cerebellum, and the cerebellum is going to make two loops. I've only described one before, but I'm going to introduce another loop here. The cerebellum is going to communicate through the thalamus to the frontal lobe to help package that movement better. It's also going to go right in here to the midbrain to a place called the red nucleus. It's going to go through the red nucleus, and the red nucleus is going to go down what's called the rubrospinal tract, rubro and red nucleus. Rubros from the red nucleus. So we're going to have a rubrospinal tract, and what it does is it controls the flexors. So what happens when you have a messed up cerebellum, you can have lack of control of extensor muscles, lack of control of flexor muscles, and when this happens, you can have a state of hypotonia or asthenia, just weakness in the body. Now, what we will see a lot of times, if you will see somebody in the anatomical position when they're standing in front of you, you'll see that their shoulders, if they're having problems and they're sympathetic dominant, you're going to see their shoulders are going to roll forward, and you can notice this, and I'll show you a picture of this, but you can see the backs of their hands, instead of them being like a pistol grip where they should be, the backs of their hands are shown because their shoulders are rotating. This is because the extensor muscles have weakened, and now the flexors, midbrain, sympathetic nervous system, is now overshooting the runway, and we have these people with chronic lower neck pain, shoulder pain. These are the people that go in, they have operations for their you know, their rotator cuff and so on and so forth. Because what happens when that shoulder rotates anterior like that, it puts strain on the rotator cuff. It gives them mid-back pain, lower neck pain, and they're always begging to be adjusted and all these other things. But what's happening is, in many of these cases, is there's a problem in the cerebellum and how it's coordinating between the extensors and the flexors. So, all right, so wide stance gait is also something very important you're going to see in a lot of these folks. So, all right, so now we need to talk about the last difficult subject as it pertains to the cerebellum. I want to summarize just a little bit, because here again, we want to, I know this is academic, this is a tough one, but I want to really do our best to make this understandable, because it really is important to understand this, to understand what the exam is all about with the cerebellum. Okay, so first we talked about three functional divisions. We have the vestibular cerebellum, we have the spinal cerebellum, and we have the cerebral spinal cerebellum. The cerebrospinal cerebellum gets all of its input and output into the brain. The spino gets it from the body and back to the body, and the vestibulo gets it from the vestibular nucleus and eyes, ocular input, and goes back both ways. Okay, so those are those basics. You have things that are called peduncles. That's how the cerebellum largely communicates back and forth from all those different parts. Then what we have inside the cerebellum, as we discussed, inside the cerebellum, let's take the cerebellum like this. Inside the deep depth part of the cerebellum, we have a vestibular nucleus, we have our inner post nucleus, and we have our dentate nucleus. All right, this is called globus emboliform, or just another way to say it is interposed nucleus. Interposed nucleus. And this is the vestigial, and that's the dentate. The important part about that is this. There is a major gating system. What's a gate? A gate is something that stops something, that blocks it from happening, inhibits it. You have a major gating system over these nuclei. What do these nuclei do? When they fire off. When they get activated, they move. When they get activated, they move. You touch them, they go, right? So we have to have a system to be able to make sure that they're not overdoing, because how much activation is coming into our body all the time? How much eye input is coming up? How much vestibular input? How much brain input? How much input is coming from our body, proprioception? How much input is coming in at any given moment? We've got millions and millions of bits of information coming in all the time. So we have to be able to inhibit those bits of information in such a way to make sure we're making appropriate reactions and actions and thoughts and different things here. So we have what is called the climbing fibers. That is what comes from the inferior olive, what we talked about. There's another type of fiber that's called the mossy fibers. Mossy fibers basically come from everywhere else, from the eyes, vestibular, brain, body, mossy fibers. Mossy fibers and the inferior nucleus, and the climbing fibers can both go to what's called Purkinje cells. Purkinje cells are on the outside of the cerebellum. They're in the cortex of the cerebellum. And these are largely inhibitory. So when something hits the Purkinje cell, the very first thing, it's the Debbie Downer. It's the one that says, no, not going to do it. Nope, not going to do it. Nope, not going to do it. Nope, not going to do it. Well, the inferior olive primarily speaks just to the Purkinje cells, and then the information goes to that way. The mossy fibers can also talk to other guys that don't inhibit but can excite. So there's this interplay that happens between excitation and inhibition in the cortex, And this is where the decision is made that says, okay, let's go ahead and fire the dentate nucleus. Once the dentate nucleus is fired, then an appropriate reaction happens. But before you even get to the dentate the dentate nucleus, or before you get to the interpost, or before you get to the vestigial, before that happens, it has to go through this process of the Purkinje cells, the granule cells, and such. Okay? So here's just another picture of this. We have our Purkinje cells right here. We have basket cells, granule cells, and I like diagrams, so let's look at the diagram. Here's our mossy fibers. Some of the mossy fibers can go straight to the deep nuclei, and the plus means it activates. But mossy fibers will also go to granule cells, which will come over here and activate the Purkinje system. The Purkinje system has the negative, so it will block the reaction. So this is the basic schematic. We don't really need to delve any further into this. Just understand that there are things that can affect how those deep nuclei are going to function in the cerebellum. Okay, we have a few more things to talk about. I think we have most of the heavy lifting done. All right, so since the floccular nodular lobe deals with axial controls and vestibular reflexes, a pathology of this system could give the following disturbances. So vestibular cerebellum, think about it in the sense of vestibular system and your ocular input. You can have equilibrium problems or gait ataxia. This is a midline lesion, and when the patient lays down or there's a loss of vestibular influence into the lesion, the patient does not demonstrate any deficits. Okay, so if you have equilibrium problems, dizziness problems, and it is from something that's coming inside the brain, you're going to see a basic thing that happens. Inside the brain, when your eyes are open, things are better. When you focus or fovealize on something, things are better. When it's coming from a peripheral, which is not in the brain, but if it's coming from a peripheral source, then things get worse when eyes are closed. Now, if you've ever been inebriated, you're going to know about that one. You lay down in bed and you close your eyes. You're like, oh, I can't do this. So you have problems there. Okay. All right, so vestibular cerebellum, here's some things you're going to see. You're going to see a vestibular ocular reflex response, a VOR response, which I will demonstrate. I'm going to talk about it in just a minute. I'm going to go through this list and I'm going to talk about the ones we need to talk about. Titubation, we talked about that. Usually of the head, could be any part of the body, just kind of a rhythmic tremor action. Ataxia of stance, that's where you're just standing there and you can't keep your balance. Ataxia gait, you're walking and of course you're stumbling around. Head tilt, very interesting. I'm going to discuss that in just a moment. Dysarthria, that's the Katharine Hepburn speech talk. And psychotic pursuits, what is this? Okay, well, we have eyes here, okay, and you put something in front of somebody and you have them follow it with their eyes. So they go this way, they go that way, and so on and so forth. There should be a smooth pursuit. But if you have a cerebellar issue, and sometimes it can come from the brainstem itself, but right now let's just keep it cerebellum. If you have let's just say it this way: if you have an issue in the cerebellum and or brainstem, then what you're going to see is that when the eyes are moving, they will either be too slow, and then all of a sudden they got to catch up. They got to catch up. They got to catch up. So you don't see a real smooth. You see a jerky pursuit, and that jerkiness is a saccade. A saccade is moving to a target. When you are saccading, it's a normal activity for your eyes to move from point A to point B. You move from here to that target, back to that target. That's saccading to a target. But when you're doing a smooth pursuit, either your eyes, because the muscle control isn't correct, you have dysmetria, the muscle control is not correct, and your eyes are going too fast or too slow, and then every once in a while they have to catch up or slow down, and when they do that, they're saccading back to that target that you're focusing on. Then we have dysmetria of saccades. That's a whole different thing. That's basically, and let me just draw it here. that's basically where we have a target here and a target here, and we have the patient here. Here's the nose and the eyes and so forth. And you tell them, look here. They look there. Then you have them look here. Then they look here. But when they look here, you notice their eye goes there and overshoots the runway and then comes back a little bit. That would be dysmetria. That would be that would be called hypermetria or hypermetric, because it shot too far, then it bounced back. Or let's say you're going to that eye and here's the target right here and it goes to here, then it catches up. That would be hypometria. But basically what we would call that would be dysmetria of saccades. I'm going to show you examples of this, so don't get too overly concerned with that. Now let's look at the vestibular. Here's our afferents. Afferents, that's what's coming in, remember. So comes from the vestibular nerve, comes in here, and our output goes here, goes up to the medial longitudinal fasciculus. That's what that is, medial longitudinal fasciculus, which is controlling cranial nerves 3, 4, and 6, which has to do with eye movements. So that's your eye. I didn't do that right. Eye movements. Okay, and also going this way to control balance to keep you upright, depending on what you're seeing in your vestibular apparatus. Okay. Head tilts, these are very interesting as well. It's not the only reason, but one of the reasons, and one of the dominating reasons why people have head tilts, it doesn't have anything to do with the alignment of the cervical spine directly, possibly indirectly it does. But your head is going to lean towards the weak brain side. So your head is going to lean towards the weak brain side. So if you have a weak right brain, you're tilting toward the right side, so you're going to have a high ear on the left. Okay? Now, if you have a weak brain on the right, what does that coincide with the cerebellum? A weak left cerebellum. Because those work together. If you see a weak cerebellum on the left, you're going to usually see a weak right brain, and vice versa. So what will happen in some cases is, like, let's say this person, this is the right side on this person, this is left side. Let's say the person has a weak brain on the right side and the left cerebellum is going to be weak. It's not an absolute rule, because there's other things that can drive that. But to keep it from this, if I see a head tilt like this, I'm going to scrutinize definitely what's going on with that left cerebellum. I'm going to look. I'm also going to ask some questions about what's going on with the right brain. Do you have problems remembering faces? Do you have, do you have fear? Do you have, the different things that go with right brain? Okay, so spinal cerebellum, lesions in the midline cerebellum or vermal region will give you symptoms such as gait instability, ataxia of trunk, titubation comes up again, saccadic dysmetria, vertiginous activity. All these things begin to overlap, don't they? Okay, so you get the input. If you look at this right here, you're getting input from the body, and then your output is going to go through the red nucleus. Remember that? Those are the flexors. And then we're going to go down here through the reticulo, vestibular spinal tracts, controlling movement, and so on and so forth. Cerebellar has more to do with dysdiacokinesia. Why is this? Because when we do dysdiacokinesia, it's usually done with the hands, feet, fingers, and these are more lateral. And because these are more lateral, they have to do with more laterality of the cerebellum, which is cerebrocerebellum. So if somebody has problems with dysdiacokinesia, the next thing I'm going to be asking, and next thing I'm going to be looking at, is how's that frontal lobe looking, right? Because of these actions. Well, how's the brain looking? Hypotonia, we explained that before. Intention tremor, dysmetria, dysarthria, impaired check, ataxia stance, ataxia gait. Immune dysregulation, movement decomposition, I should say, and ocular disturbances. Yeah, the immune system is definitely in play. In the there's research out there that shows that an impaired lateral cerebellum impacts in a negative way the immune system. So the cerebellum, we're just about finished here. The projections from the cerebellar cortex to the dentate have interactions with the parvocellular red nucleus that does not comprise aspects of the cerebrospinal pathway like the spinal cerebellar does. Rather, it has red nuclear projections. Okay, I think this is okay. We don't need this. All right, so the cerebellum is going to get its input from the brain and then back to the brain. So to and from the brain. So as a review of the cerebellar deep nuclei and somatic control. Vestigial, you're going to see that control over the spine. Globus and emboliform, you're going to see shoulders and hips, elbows and knees, and the dentate, you're going to see hands and feet. How does this mean to you practically? If somebody has poor coordination with their hands and feet, I'm going to think, what is going on with that brain? If somebody has problems with their joints, of their shoulders, their hips, their elbows and knees, I'm going to think about postural muscles. I want to think about what's going on with their spinal cerebellar system, and if they have problems with their spine. What would it look like to have problems with the spine? A lot of people will have issues like, man, if I sit down for an hour more, my neck just kills me, or my back just hurts if I sit down for over an hour. Or if I stand for an hour, man, my back just kills me. This could be a vestigial nucleus coming out of that area. Okay, so cerebellar functional summary. Balance and equilibrium, calibrates motor movement, calibrates cognition, language, social behavior, limbic system, influences the autonomic nervous system, and activates the frontal lobe. There's a lot of things going on in cerebellum. This next video, we're going to put practical wheels on that and start doing the examination.